On this episode of War Docs, we speak with critical care nurse and former Army National Guard flight paramedic Abraham Boxx, also known as Boxy. Boxy shares the story of starting off as a medic in the Australian Defence Forces and training to become a paramedic and later a flight paramedic 68 Whiskey Foxtrot 2 in the Army National Guard in the United States. He talks about deployments around the globe to places like Malaysia, the Solomon Islands, Pakistan, and Kosovo, and lessons learned providing care in austere environments. He speaks about the similarities and differences in paramedic training and experience between Australian and U.S. forces, and stresses the essential skills and qualities required to accomplish the mission. Boxy also shares information about obtaining additional training in medicine, and describes what led him to pursue becoming a CRNA and the ways available to have the military pay for his education. Find out more about Boxy and our previous guests on our website, wardocspodcast.com. And make sure you follow War Docs on your preferred podcast platform, and subscribe to our War Docs YouTube channel. I'm your host, Dr. Doug Soderdahl, retired Army urologist, and I'm joined today by my co-host, Dr. Wayne Causey, active duty vascular surgeon.
Welcome to War Docs, the military medicine podcast. This show brings you a first-hand, behind-the-scenes look into the mission, unique opportunities, and deployed experiences of the entire military healthcare team. From state-of-the-art hospitals in the United States to the most austere environments across the globe, War Docs has you covered.
Today, we're privileged to welcome critical care registered nurse and prior Army National Guard flight paramedic Abraham Boxx to War Docs. Boxy, thanks for joining us today.
Thanks so much for having me, guys. I'm a long-time listener, first-time, obviously, interviewee, but super glad to be here.
We're excited to have you, Boxy. So we'll start by saying you grew up in New South Wales, Australia. Many of our listeners may not know much about this area, so please tell us about your early childhood and why you joined the Australian military.
Sure. Yeah, I grew up in, so the accent's from Australia, born and raised there. I grew up in rural New South Wales, about 5 hours outside of Sydney. Very, very rural, the kind of place where you don't have running water, kind of rural. That was one of the biggest inspirations for me to join the military. So I was homeschooled, and initially I was going to go be a veterinarian doctor. But when I realized there wasn't a lot of travel opportunity and the money didn't really compensate for 6 years of university, the military seemed like a really, really good opportunity. Specifically as a combat medic, a few years before I joined, the Bandi Aceh tsunami hit in December 2004. Basically wiped out a lot of Southeast Asia, 350,000 plus dead. And we saw a lot of coverage with the Australian Defence Force, ADF, Royal Australian Army Medical Corps, the Navy and the Air Force go over and support them. So I think at an early age, that was end of 2004, like I said, 2 years before I joined, that was a huge motivator for me to want to kind of join the Defense Force and go over and help other countries.
So how did you get interested in the medical side of the military? Was that something that you always wanted to do or something that you kind of fell into?
It definitely wasn't something I always wanted to do. I mean, truth be told, as a kid growing up in the bush, I always wanted to be an army sniper, which is kind of very contradictory to being a medic. But honestly, the order I got when I joined the Australian Defence Force, April 2007, a long time ago now. The idea of being a medic and being able to help people and being able to bring an additional set of skills to remote locations across the world really did appeal to me. Australian medics are very well trained, but they're also similar to this military, infantry first or gunslingers first. So I like the fact that I could be trained up in that role, but then have those additional useful skills if I ever wanted to get out of the military.
So we do track a little bit of our listener base, and there are quite a few listeners that we have that listen from Australia, just like you had mentioned. And you joined the U.S. Army National Guard in 2016, so you're able to compare military medical care in the United States and Australia. Tell us about military medical training in Australia and how it may differ from the United States military training.
So my reserve element, I was a reservist in the Australian Defence Force, which aligned very similar to what active duty counterparts did at the time. So I did a bunch of face-to-face courses that were between 2 and 4 weeks long, and then you did clinical placements as well as online learning and distance education modules. Since being in the Australian Defence Force and seeing the gaps in what we were being trained and versus what our medics were experiencing in countries like the Solomon Islands, East Timor, Afghanistan, and Iraq, they actually revamped the entire MOS training in Australia. So now it's actually quite lengthy. It surprises a lot of Americans when I say our medics in Australia now do 18 months of full-time combat medic training. And that is your basic medic. That is not your special operations medic. That's not your UMs or underwater medics for the Navy Special Warfare units in Australia. There's a huge emphasis on primary healthcare and treatment of primary health conditions and diagnosing and assessing and things like that. They obviously do a lot of TCCC training. However, seeing the big gaps in primary healthcare, antibiotic treatments, pediatrics, OB, that I would say is one of the biggest differences I've seen. Coming to America, I had the, I'll call it opportunity to do both training. So I went through basic training again in the U.S. forces at Fort Sill, Oklahoma. And then I went through the entirety of the 68 Whiskey pipeline as well. That's a 16-week course. I was an accelerant because I was already an EMT here, certified in America as a paramedic, but they waived the first 8 weeks. What I did see the difference was obviously the length of training, 16 weeks versus 18 months. Australians will be qualified to get essentially their associate's degree in EMS and an associate's degree in nursing at the end of that 18 months of training. I see benefits to both, with the 68 Whiskies in the U.S. Army being the second largest MOS in the Army, secondary to 11 Bravos or the infantry. There is kind of a push to get these people through training and get them to the lines where they need to be utilized. So I can definitely see why both have their way of doing things.
So you went on for further training and trained to become a flight paramedic. How is that different from being a non-flight paramedic, and what additional training did you do, and what was that like?
Great question. So the Army pipeline, this is a very rewarding story. My old unit, the 1168 out of Nevada and Washington and California National Guard, deployed in 2008. And there's a reason I'm telling you all this. They saw a big intake in survivability of combat-related injuries while they were deployed to Afghanistan, Iraq, and the Middle East area of operations, with the National Guard flight medics going over and deploying in that capability versus the active duty. They identified there was a gap in training from active duty who were essentially exceptionally good ground medics who had done the 68 Whiskey course, which was, like I said, 16 weeks long. And then they had done an additional maybe 1 to 2 weeks of flight medic training, ACLS, PALS, and PHTLS. When the National Guard medevac took over, they actually saw a jump in over 60% increase in survivability rate with using their protocols that they used as civilian providers back in America. It took a while, but America, the U.S. Defense Force did get on board with it and increase the pipeline of the flight medic training. So now they will still do basic training. They'll still do 68 Whiskey basic course, which is 16 weeks long. And then they'll follow on to do the actual paramedic program, which is now 26 to 30 weeks long at San Antonio, followed by an additional 8 weeks of critical care school or the Fox 2 school. And then they'll actually do the Fox 3 school, which is the flight crew member aviation course in Fort Rucker, Alabama. So you're looking now at almost a 2-year pipeline to make very, very good and very qualified flight paramedics. I won't say lucky because I kind of did it a backwards way. I got trained in the civilian sector completely in Australia. And when I came to America, I actually redid all my training again because that's the American way. So I redid BLS. I redid my EMT school. An accelerated EMT program at UCLA. I redid paramedic school, an accelerated program in Nebraska, and then started working as a civilian provider and did a bunch of critical care courses through that. Why I'm telling you this is I actually applied for recognition of prior learning or recognition of prior competencies, and I actually was allowed to waiver the critical care school, the paramedic school, and the aviation crew member school. So I actually got my Fox 2 designation, which is the critical care flight paramedic, through a lot of civilian training that I had done, which is an amazing opportunity for people who are, I'll just give a plug there, amazing opportunity for people who are already certified flight paramedics who want to kind of go into that role in the military.
Yeah, that's great advice for people. And it also seems from your biography that you also had many deployments with the Australian military as a combat medic to Malaysia, Singapore, and Pakistan, and other locations in Southeast Asia. Tell us about the Australian military and the support to this region.
I deployed a couple of times with the Australian Defence Force and then an additional time to the Middle East with a humanitarian aid organization. Australia, obviously part of the NATO alliance, we have a lot of partnerships with our Southeast Asia continents around us as allies. This goes back to pre-World War II and when there was threats up in Southeast Asia that were coming down to Australia. So we have those long-standing ties with those militaries. My first deployment, I cut my teeth as a medic, was late 2009 to Southeast Asia, so Malaysia and Singapore, with a rifle company called Rifle Company Butterworth. It's a rotation that the Australian military, predominantly the Army, goes out to a Malaysian Air Force base and does training for 3 months there to build alliances with those forces. So we did a lot of jungle survival training, counter-drug training, jungle warfare, military operations over urban terrain. We had the amazing opportunity to go to the Singapore purpose-built urban terrain facility and actually have wargaming in a city, a 2,500 person city. So that was a great training opportunity, as much as it was as a deployment, because like I always try to tell the baby medics now, even if you're training, you're still going to be used as a medic. So my second deployment actually followed on. I got home, and it was on that first deployment I was told, you're deploying again 6 weeks after you get back, because they need a medic with the Tongan Army, the Tongan Defence Force. So we deployed to Regional Assistance Mission to the Solomon Islands, or RAMSI, Rotation 21, with our a combined task force made up of New Zealanders, Tongans, Papua New Guinean forces, Fiji Police Force, and the Australian Federal Police. This was a peacekeeping, by the true sense of the word, a peacekeeping mission. In the early 2000s, there was a lot of genocide and infighting between the islands, whereas the Australians and the New Zealanders had to step in and assist from the genocide from occurring. So our mission there was predominantly peacekeeping, but we also had the amazing opportunity to do medical aid. So myself and other medics rotated through Honiara Emergency Department, Hospital and Surgical Center in Honiara, which was, we won't say third world, but a very developing hospital. I would say professionally, that was the biggest eye opener for me as a baby medic at the time, at 22 years old, to actually see what you're learning in a textbook and the face of it in real life. Shortly after that, I was on a roll, so I got back, and 3 months later, I deployed again to Pakistan in late 2010. So the timeline, Australian deployments are a little bit shorter than the military here in America. I've done one with the US Army. It was definitely the longest one, but Pakistan was an amazing opportunity to provide humanitarian aid with a organization that was actually developed by the Australian Special Forces commandos, who had actually gotten out of active duty military and reserves. And they saw a gap in humanitarian aid and opportunities to help these people in some of these countries. And they designed their own humanitarian aid organization. And they sourced a lot of their volunteers, like myself, from the military with that very unique background of being able to provide medical care in austere environments. So I had the great opportunity to go to Pakistan in Sindh province in the Thatta district to provide mobile healthcare teams, female hygiene distribution clinics, primary healthcare clinics, and really, for me, professionally getting to see some of these diseases and disease processes that we had learned about, such as like TB or cerebral malaria and things like that, that I'd never, ever had the opportunity to see in Australia, that I was seeing firsthand in the Middle East. So
one question I have about that is, what kind of support do you have as a medic? Are there nurse practitioners, PAs, docs? When you're confronted with stuff that you never see back home, what's the next step, and what was your capabilities, and how well did you feel like you were supported medically?
With the humanitarian aid group, Australian Aid International, was very well supported. So we had a very experienced nurse with me on my team. She had been a nurse quite a long time and had deployed multiple times. And then I had some junior doctors as well. And then we also worked hand in hand with our local partners in Pakistan to provide medical services as well. So I felt very much supported on that deployment. That being said, though, I'll be completely upfront, because I'm no longer in the Australian Defence Force. I didn't feel as supported as I would have liked. And I allude to this on another podcast with the World of Extreme Medicine I got interviewed a few months ago. This is a big gap in supporting junior medics and making them better, and maybe giving them more, what am I trying to say here? We were trained to believe that we were very, very capable on our own. In 2007, when I was training, there was not a lot of talk of online medical control. There was no medical direction. Our protocols were very expansive, but we were taught that you know everything, you'll be fine, you'll do it all yourself. When I deployed to the Solomon Islands, it was me and two other medics. The highest rank was a corporal. So we were in charge of 120 Australian Defence Force members on that deployment. My first deployment to Malaysia, there was no military assets there except for me and one other medic who was a lance corporal, and we were in charge of another 110 Australian Defence Force members. It was a great learning opportunity. We utilized the civilian medical facilities exceptionally well in those countries. They loved having the Australian Defence Force there. We paid cash, so they definitely helped us. However, it is definitely something as I developed, and I'm almost 37 now and have a license, and I'm a provider now. It is definitely something that I wipe away the sweat just thinking about, that's how we practiced back then. And it is something on my fourth deployment, my deployment with the US military, that it is something I definitely vocalize a lot more about, knowing your limitations, preparing yourself for things that the military may not have potentially trained you for, like pediatrics or obstetric emergencies and things like that.
I also wanted to know about any lessons learned, because you had the opportunity to deploy with very little supervision, much more with Humanitarian, one with the Australian Defence Forces, one with the United States. So you've got a lot of experience in a lot of different deployment environments. What would you say is a lesson that you've learned that you say, man, baby medics, you got to know this when you go places?
It's great. And then honestly, it's something I put it there. And I teach as well. I teach the critical care paramedic program, and I teach some other places. And I always finish with knowledge weighs nothing in your rucksack. It's twofold. That statement's twofold. One is knowing your limitations of when to say, I don't know what to do next. I need to find out who does. So I'm a very big proponent of online medical direction, or a lot of us think it's boring as baby medics, but that mission rehearsal planning of what if we get to the end of our tether and we don't know what else, or we don't have the resources to do it. The other biggest lesson I learned was, and I've seen this in both militaries extensively in military medicine, is exposure to unique populations that the military just flat out does not teach medics. Obstetrics and pediatrics is not something that is taught, and I've done both trainings, and I'm always digging into the CPG, clinical practice guidelines, and I'm keeping my finger on the pulse of what they're teaching at San Antonio and even back home with the Australian Defence Force. And it is, you are a combat medic, you're a medic designed to treat soldiers, which makes perfect sense until you deploy. And any local or any village or any rural area that you go out to and they see that Red Cross, they're going to see you as a doctor and they're going to ask for help. It is a really hard pill to swallow to say, I don't know what to do, I can't help you because you're a pediatric or your age is under 18 or you're not a military age male that I was taught to treat. Or, I'm really good at doing NCDs and chest tubes and tourniquets, but I can't treat urticaria. I don't know what to do with bed bugs. I don't know how to discuss malnutrition on a lady who's about to give birth. So I would say one of the biggest things I'm a proponent for is digging into those and getting clinical exposure to unique populations that you will 100% see. Every one of my deployments now in humanitarian aid the world over, they are the ones that need our healthcare. Be really good at the basics, be really good at TCCC, but if you expect to deploy and be exposed to any amount of civilian population, that's what they need to dig into. And that's why I teach it. I try to get the knowledge out there as much as I can.
So one of the things that we do for each guest is we do a little homework and research on them. And one of the first places we go is to Google. And so when I typed in your name, I found that there was an awesome picture of you rappelling out of a helicopter. But one of the unique things about the picture was that you had a face mask with an Australian flag painted on it. First off, do you happen to have that mask with you? And second, tell us about the significance of that mask.
Army aviation is very big on esprit de corps. All the jokes about, how do you know when an Army pilot walks into a room? Don't worry, he'll tell you. We like to stand out and show off. So it is twofold. One, it kind of represents the uniqueness of Army aviation and our esprit de corps of what we do, and how, our flight suits are different than the normal uniforms. everyone's always excited about the helicopters. The second one is my wife actually painted that mask for me. She's a bit of an artist as well. She's doing nursing school, but she's a bit of an artist, and she wanted to demonstrate when I was on deployment that she could see me in any of the photos, because a lot of us are always wearing masks. So she actually painted that uniquely to represent that she'll always be able to see her at the time, future husband. The more it picked up, we got interviewed a few times, our Army Aviation, in our Task Force Griffin in our last deployment to Kosovo. A lot of people started getting very interested in that mask. So they did actually 3 different interviews about that mask on deployment. So now whenever anyone Googles it, that actually what pops up. And that's one of the advertisements now for Army Aviation for recruitment purposes. So, yeah, I'm very, very proud
Join
of
the
that
Army,
mask.
you can become Australian.
Exactly, dual citizenship. It's very unique. A lot of the guys kind of ragged on me about it because military protocol says don't alter anything about your uniforms, especially in aviation. And then they went ahead and published multiple articles on how great this face mask looks. So it was a great time.
So one of the things that you've done subsequently is that you've trained and are critical care registered nurse. And how would you say that your experiences as a medic, paramedic, flight paramedic, how did that really shape your ability and approach to healthcare and taking care of patients?
I think wholeheartedly, it was a benefit having that out of hospital exposure and experience, the autonomy that paramedics bring to an environment to be able to work independently, especially in Australia, where online medical control wasn't really a thing. Again, very expansive protocols, degree requirements to be paramedics. That background helped me a lot. My 6 years in critical care flight, both in the Army National Guard as well as the civilian sector, prepared me exceptionally well for the ICU, the intensive care unit or critical care unit that I work in. I'm now in a trauma surgical ICU. And when I started, I worked in a mixed medical trauma ICU here in Oregon as a new graduate. Combining both of those and being willing to learn and still open my eyes after 16 years as a paramedic and be like, I'm a new nurse now. I need to be able to learn. I think that comes with experience and maturity, which I got a lot of that from being a medic. So that helped a lot. The job itself, people are always people. People bleed the same. People breathe the same. But the environment is very, very different. I would say I was very capable and very confident as a flight provider with multiple years of experience and kind of seen it all, done it all. And then I went to the hospital into a critical care unit. And even with that experience behind me, it was still a very steep learning curve to be like thousands of different medications, thousands of different unique medical conditions that we really aren't exposed to too much in pre-hospital care. Or if we are, we kind of get them to hospital and be like, all right, now it's your problem. So I think it helped definitely, but I think the right paramedic also understands that it's okay to be the probationer again. It's okay to be the new guy again. As long as you're willing to learn, I think that experience will be great for you, like it was for me.
So I'm listening to your story and I'm hearing, well, I work as in a trauma ICU. I'm a critical care flight paramedic. I'm in the U.S. Army National Guard. Tell us about just what that encompasses for you. So like 1 week you might be doing this, on the weekends, just sort of give us an idea of your life at the present where you're in the National Guard. You're also working a civilian job. Take us through that.
Well, actually, right now it's kind of a unique situation. I actually ETS'd out of the Guard late last year in preparation for transitioning to graduate school to complete nurse anesthesia school. So with that, the requirements for being in flight obviously was more than just 1 weekend a month. I did 6 years in the Guard, absolutely loved it, did a deployment, made rank of sergeant, was on the OML for E6. However, trajectory at almost 37 years old and being enlisted for 16 years, the dark side started beckoning a little bit more, and the opportunities of being a commissioned officer in the U.S. Army Reserves definitely appealed to me. So more recently, I would say a lot's changed. When I was drilling, it encompassed, my 1 weekend a month with additional flight hours, with additional MOS specific training, such as like ACLS, PALS, PHTLS courses frequently. And then for me, being in my old unit, being a training NCOIC, that also presented unique challenges and opportunities to make classes and lessons and things like that to stimulate the medical people in my unit. Whereas more recently, my shift has heavily been towards becoming very proficient as a critical care nurse. In the first year after I graduated nursing school and started working in the ICU, I got the big four specialty certifications. So I got my trauma certified registered nurse, certified flight registered nurse, critical care registered nurse certification, and certified emergency nurse certification. I shadowed weeks at a time with CRNAs, and then ended up, against my wife's wishes, going on a lot of little trips myself across the country to look at facilities and schools that would be a good fit for nurse anesthesia. So I think to answer your question, the last 6 months, a lot of that focus has actually been towards getting ready for STRAP, or the specialized training assistance program that the military offers a stipend to help pay for graduate school and things like that. So that's kind of where my life's been going in preparation for the next step of my medical career.
So when you become a CRNA, you're going to need a whole bunch of extra space for all those credentials after your name. You just have quite an impressive list.
It's unique. People laugh because no one has met a new grad who started getting specialty certifications 12 weeks into their first job. But as I kept reminding people, it was to make myself appealing for CRNA school. And I only put the big ones on the business card. I don't put things like ACLS and PALS. I've seen that, but I don't do that. But no, honestly, it was to make myself very appealing to the very, very competitive school that is CRNA school.
In all your experiences as a flight paramedic or a flight nurse, what was the most memorable case, whether it's a civilian case or deployed or wherever? What was your most challenging, memorable case?
The most memorable case would have been me as a junior medic, actually. The more I developed into this career field, we were actually talking about this at the hospital the other night to some junior nurses. I was taught that one of the really good defense mechanisms in this job is a short memory. I didn't get it at the time, but a lot of the patients now almost gel together. And as quickly as we pick them up and drop them off, or even in the ICU, they're out of sight, out of mind. So we don't kind of, live with those, demons or skeletons in our closet. However, one of the most memorable cases for me is also one of the reasons why I push those unique populations we discussed earlier. It was a pediatric patient in the Solomon Islands back in 2010 who had fallen out of a tree collecting coconuts for his family. He had presented to the number 9 hospital, or Honiara Regional Hospital. And to give you an idea, this emergency department was a hard rock floor with no AC. You're 100 degrees outside, humidity 100%. Very underdeveloped medical system, relied on a lot of volunteers and relied on donations. Dressings really were made out of dresses and sheets. I was there with another medic from the Australian Defence Force. This kid presented initially. We were assisting the nursing staff. There was no doctors. We were assisting the nursing staff. He had a dislocated shoulder from falling out of the tree. He also had a broken ulnar in his arm. And he also had a small pneumothorax, or what we thought was a pneumothorax. So we relatively easily, air splintered his arm. We reducted his shoulder dislocation, reduced his shoulder dislocation, which is something the Australian medics were taught. And then we did a pediatric NCD, which essentially is a 20 gauge IV with the cannula. So this kid unfortunately deteriorated. It's actually quite sad. He deteriorated fairly rapidly and developed a pneumothorax where we were required to put in a chest tube. We put in an adult-sized chest tube because I didn't have pediatric chest tubes. He was a bigger 12-year-old, so that worked well. But the thing I'll never forget was how much he bled when we put in the chest tube. It was their chest tube system, and they taped it. I'll never forget. They duct taped it to the side of the pediatric patient. They put the underwater chest seal into a cardboard box on the floor. That was their way of keeping it upright. And the tube itself had tape on it to stop air leaks. Crude but effective. We did that, and we gave him some pain relief, and we were managing his airway and things like that with a non-rebreather mask, and he was conscious. But to surmise the story, and this is quickly where I learned limitations and resource scarce environments and the impact it can have on my patients. When we said, okay, where's the surgeon? He needs to go to surgery to get this bleed controlled because he's still actively pouring blood out. It had apparently tamponaded itself initially and then kind of just burst. And they said, well, he's going to die. And the nurses told us he's going to die. And we said, why? There's a surgeon that can't do this. You guys don't have a cardiothoracic surgeon or anything like that. And they said, no, the surgeon lives 8 hours away in a car and he'll be dead before he even comes here. So the surgeon said he's not coming. And he lived on the other side of the island, and it was an 8-hour drive, and the surgeon wasn't malicious or horrible person or anything like that. It was the reality of what we were doing. As a 22-year-old baby medic who was taught no one dies, every scenario ends on a happy note because you've just done all the right things, you've done your NCD, you've done your pain relief, all that. We were very proud up until that point. And then the reality was his family said, can you make him comfortable? So we essentially, as baby medics in the Australian Defence Force with no medical oversight, made this child comfortable with morphine pushes. We weren't using ketamine or fentanyl at the time, nor did they have it. And we essentially assisted this child into palliative care immediately, and he died. He bled to death. That one stuck with me. I mean, luckily it's not morning time. I'm not too emotional about it now, but that one stuck with me because it was a great reminder and motivator for me to go, I don't know pediatric stuff. I don't know these interventions. I don't know how to do, blood to blood transfusions at that time, or maybe we could buy more time. Knowing what I know now, I would have done many things differently. But that one stuck with me a lot. And I think in a positive way, it stuck with me as a learning lesson. When I went back to Australia shortly after that, I'm articulated into my Bachelor of Paramedicine because I did teach pediatrics and OB. The critical care transport team I worked with in Alaska, LifeMed Alaska, was the only transport service that offered high-risk OB training and high-risk OB transports. Now that I teach it, I teach high-risk OB complications and pediatric complications and pediatric trauma because despite what people say, they're not just little adults. They're the whole different ballgame. So I think that one stuck with me the most. In 17 and a half years of EMS now, or 17 and a half years of healthcare. That one definitely stuck with me the most.
Right. The point that you brought up is one that many of our guests have brought up through our interviews, and that's understanding the local, or what we call host nation capabilities. And so understanding what type of medical care they can receive if we provide treatment is sometimes difficult to understand because we come from a very resource abundant society. One of the things that you have unique experience in is that you not only have been a medic at the point of care, but you've also been a medic in the transfer from roles of care from one to another. And so what I mean by that is in order to safely transport a patient from, say, point of care to role 1 or role 1 to role 2 or 2 to 3, there is the need to have specially trained medical individuals such as you, critical care flight paramedics, that help get those patients safely from one location to another. What are some of the key skills or qualities you believe are essential for these types of medical professionals, especially when we start thinking about the need for providing those capabilities during prolonged field care situations and future conflicts?
It's a great question. Honestly, I think a kumbaya response would be maturity and coachability is something innately I've learned being in this field for this long and going through being the probationer again and again and again. Being humble enough to learn that someone who just graduated AIT might know more current medicine about a specific topic. Why I say that is because, especially with the Guard and Reserve, we have, and even active duty, we have a unique skill set that we can also bring to our MOS, whether you're a plumber or an electrician who's an 11 Bravo, they may be able to set up lights and things like that in your medical facility. However, their primary MOS is an 11 Bravo. So without having the guts to basically say, hey, do you have a better solution for this? And that's where the coachability and humbleness comes in. In regards to future conflicts, a lot of talks have been, and I won't talk politics, but a lot of talks have been that Army aviation will be grounded. And a lot of these Fox 2 roles will actually be filling roles as kind of senior medics in these FRSTs or forward resuscitation surgical teams and things like that, or these ground hospitals, simply because we cannot risk having all of our helicopters shot down and our medevac assets getting shot down. So already the Army's identified this problem that prolonged field care and near-peer forces and a large-scale combat operations is the new flavor word, that there is an issue with it. What I would say is, having my experience more recently as well, being a nurse, I found that a lot of my nursing skills, and a lot of medics won't love this, but a lot of my basic nursing skills are things that we should be pushing future medics to get comfortable with. Long-term, holding a patient for 3 days, we need to know how to convert that tourniquet down to a safe conversion. We're looking at bed sores on patients laying on stretchers if they're not turned frequently. You're looking at Foleys so patients aren't urinating all over themselves and essentially having that break through their skin. What I talked about, basic antibiotic treatments and things like that. There is a lot of basic nursing skills that can be used by medics without without going and getting a degree or an associate's degree in nursing, that I feel would be extremely beneficial in these future conflicts of prolonged field care. And then my last thing would be, I've got a little writing here. It said, your biggest skill in a large combat scale operations where we are going to have mass casualties all the time that will completely exceed our resources is getting good at teaching other MOSs and combat arms soldiers how to do your job in a very, very basic way. So you don't necessarily have to tie up the 18 Delta to do wound care or to turn your patient every 2 hours. Having an 11 Bravo and taking them through a basic wound debridement class that you teach and you supervise as you walk past, or having them roll the patient every 2 hours, or simply just bagging someone who's intubated and sedated because we don't want to tie up the 4 ventilators we have because they need to be used for transport, is using the resources you have and being really good at teaching the basics of your job to other people. I know some organizations are better at that than others, but I feel like that would be a great resource to have.
In your experience, is there something that military medicine could learn from civilian medicine, or vice versa? Is there something that civilian medicine could learn from military medicine?
We have already learned so much from war. Having deployed this many times and seen the destruction of it, I would say the only benefit out of war is all the medical advances we've made, specifically with trauma care, use of tourniquets, whole blood administration, the vampire protocol with blood-to-blood administration, learning about the benefits of ketamine with disassociation and PTSD use for early ketamine use for traumatic patients. I feel like we've learned a lot from the military in trauma care passed into the civilian sector. One of the biggest things, and the theme of what I've been talking about most of this podcast, I think the biggest thing military medicine can learn from the civilian sector is exposure to populations and actual real world patients. They are EMT, even the basic Army medic is an EMT certified. They are certified to treat civilians. Licensing is another requirement. However, to give you an example, a paramedic school needs 400 hours of clinical exposure. My nursing degree needed 1,000 hours. My future program, the CRNA program I'm going into, needs 2,400 hours of direct patient care. Doctors after med school need residency, internships with supervision. I think the military could really hone down on having their basic medics all the way up to nurses and PAs and doctors being exposed in emergency departments, EMS organizations and things like that to get that hands-on exposure. So the first time they're not experiencing someone who's been shot or run over or heaven forbid blown up is by themselves on a battlefield somewhere in a third world country where they don't have any access to higher ups or support. Not only would the benefit the patient to have a well-rounded qualified member who's already kind of done it and seen it, but for that medic, it will also wholeheartedly help them with the mental strain of being a medic later on in life to kind of better deal with that.
What message or insight would you like to share with our audience, particularly those who may be considering a career in military medicine or critical care nursing?
I think it's the best career in the world. The opportunities it's afforded me to travel all over the world, to provide healthcare to people who may not have had access to it, selfishly is super rewarding. the opportunities, especially in nursing now in America, are as far as your imagination can go. And then to give a plug to the military, I'm biased. I've spent my entire adult life in military service. The opportunities that it has afforded me to progress not only in the military, but also my civilian career, I can't stress enough. It will take a toll on you mentally and physically, but just to understand that no matter how bad you feel like it is, you're not alone. There are resources out there, and there are great mentors you can plug in with. You can reach out to me on my Instagram. You should never, ever feel alone in this career field. And I know we're getting a lot better at that than we used to be. But yeah, I would say wholeheartedly, do it. If you're thinking about it, go for a ride along. Go meet the guys or girls who do this job. Talk to them, have them answer your questions. But I guarantee you won't be disappointed, and it's an amazing career field.
So you mentioned that you have plans to attend CRNA school and then become an officer in the U.S. military. How do you see your future career evolving, and what goals do you hope to achieve?
My future career, actually, since we started doing this podcast, we corresponding back and forth, I actually got accepted. So I know my current employer is going to hear this, but the cat's out of the bag. I actually got accepted into a double doctoral program in Louisiana at Loyola University. It's a double doctoral program in a certified registered nurse anesthesiologist, as well as adult geriatric acute care nurse practitioner. The long-term care and prescribing license in primary healthcare that I love with the acute care nurse practitioner, as well as all the interventions and skills that come with being a certified registered nurse anesthetist, was combined into a 36-month double doctoral program that I'm going to move down to Louisiana to start the next chapter of my life. So me and the wife are doing that in August. What that looks like for my military service, I'm not out of the woods yet. So like I said, I've applied for STRAP, the Specialized Training Assistance Program that the Army Reserve offers to pay a stipend and a loan forgiveness for school. Will ensure that I owe the Army Reserve 6 years of return of service in the Army Reserves as a captain, CRNA, after I graduate. So need to the Army, wherever they're going to send me, probably an FRST. That's where that's going to end. My biggest goal, my end goal would be to, just the same as like I do on these podcasts, is to stimulate change in the military for the better, to make our predominantly medics better at their job, to better serve those they're charged with serving, to help with their mental well-being, coming back and understanding that they did exactly what they were trained to do and they did the best they could at what they had, by basically me motivating people more and more to put hands-on clinical exposure and exposure to unique populations like OB and pediatrics to the future medics. And as a captain, I'm hoping that'll stimulate more change than a Lance Corporal or a Sergeant could when I was enlisted.
We've been speaking with Abraham Boxx on War Docs podcast. Boxy, thanks again for sharing your experiences and insights with us, and thanks for your service to this nation.
Thank you so much, sir. I appreciate, honestly, the opportunity to be on here, and I can't wait to hear you guys' next episode. It's a fantastic podcast. I recommend everyone to watch it.
Thank you for listening to War Docs. We sure hope you enjoyed it. War Docs is a nonprofit organization supported by donations from listeners like you. Please follow and subscribe to our show on whatever platform you consume your podcasts, and rate and review this episode, and share the show with your contacts on social media. Find out more information about our show, our guests, and how to become a member of Team War Docs on wardocspodcast.com. Thank you for your support. If you like war stories and medical drama, War Docs has you covered. Spread the word.